Welcome to Telemedicine and Pediatric Emergency Care. This is a just-in-time resource from RAPM, the Western Regional Alliance for Pediatric Emergency Management. I'm Jonathan Kohler, a pediatric surgeon at UC Davis, and I'm joined today by Jim Marson, who's a pediatric critical care physician at UC Davis Children's Hospital. Jim, welcome.
Well, thanks a lot, Dr. Kohler.
We're going to be talking about pediatric telehealth, but really your focus is on pediatric teleemergency. Is that right?
That's right. I think a lot of children's hospitals are using this more and more, but children's hospitals are very large regions and lots of different hospitals. And so more and more we're using telehealth to help initiate care of children in remote communities. And our experience at UC Davis, we've been doing it since about 2000, and there's different ways of implementing it. But at our institution in particular, we use it at about on 10% of our calls that come into our transfer center or consultation line. Usually it's for the really, really sick kids. Sometimes it's used for less sick kids to see whether or not they can stay in their own communities. And since the onset of COVID, and as we know, the triple-demic, we use it more and more when we weren't able to accept the transfers, but to help manage acutely injured children in the remote community hospitals.
And I'll be honest, I was not even aware of the full degree to which we were doing this tele-emergency care until the triple-demic hit. And I suddenly realized that there was a system in place to help these kids who were at smaller hospitals, rural hospitals, where normally children would be transferred out, and then there simply were no beds. There were no beds available, and this was a national phenomenon for these kids to transfer. Can you talk a little bit about sort of the triple-demic?
Yeah, sure. Again, I think we were fortunate to have it up and running, and all of our docs were used to using it to help evaluate children. And as you can see in the slide, it was very uncommon for us to have to deny transfers to children because of capacity issue, very low numbers. And it was just unprecedented. Again, I think a lot of the children's hospitals experienced this where we just were not capable of taking care of these kids. So we were fortunate having the technologies in place, being connected to, more than 30 different hospitals in our region to be able to help emergency medicine physicians, general pediatricians, family practitioners care for kids that otherwise would be transferred to children's hospital in place. And again, so our lesson learned from this is that pediatric teleemergency is a proven tool for emergency preparedness for sick kids. And again, you can see in the next slide, has become a focus for a lot of emergency preparedness. So I think all of these entities now are recognizing the importance of teleemergency in preparedness and surge events.
You're clearly a pioneer and a real leader and thought leader in what we can do when we think about treating patients at a distance. So maybe we could talk a little bit more about sort of the impact of telemedicine, what it can do. We can talk maybe a little bit too about what it can't.
We've been interested in this, have been conducting research for quite some time, even prior to COVID. Us and other investigators have demonstrated that when telehealth is used on consultations or interfacility transfers of sick kids, there's higher parent satisfaction when they're able to see the specialist beaming in. We have demonstrated higher emergency department physician satisfaction. They feel that the quality of the consultation that they're receiving when they're using telemedicine is higher compared to the standard of care, which is a telephone. Higher safety in terms of lower medication error rates. And as you can imagine, a more obvious one is a reduction in inappropriate transfers when we're able to say, hey, this kid isn't so sick, or more appropriate disposition, right? So this kid can either go ER to ER or can go to the ward rather than the ICU, or should go to the ICU rather than the ward. So I think there's a growing body of evidence in the literature to demonstrate that there's lots of positive impacts when these technologies are used to help see sick kids in outside facilities.
Okay, so the best time to have set up a telemedicine program is months ago. The second best time is now. But what do we do if it's 3 a.m. and suddenly you're overwhelmed with patients in your hospital and you want to get some sort of telemedicine stood up right now? Is there a way to do it?
Again, I agree with you, Dr. Kohler, that it's always best to have all of these systems up in place prior to the emergency. But if you're going to try and do it in a pinch, if you're able to talk with your legal and compliance department, they have varying degrees of issue with the risk assessment. From our legal and compliance office, they always feel that if we're doing what's right for the child in an emergency situation, that we might even be able to forego credentialing by proxy or a written agreement or a contract in place. And again, so that's our legal and compliance department. You really need to talk with your own. It's very important to have, and again, in my opinion, the higher the quality camera, the better assessment you're going to be able to do. Same thing with audio. So whether that's over the internet or over cellular, you can pick or choose, but whatever it is, that's going to give you a good image and good audio on it. And even though you might have a telemedicine system, if you're trying to connect somebody outside your telemedicine system, or if another health system has a telemedicine system and you're trying to tap into that, even though you might think that that should be easy, oftentimes IT, for legitimate security reasons, have firewalls and there can be interoperability issues. So again, you're going to probably need somebody familiar with the telehealth systems to be able to help establish your video and audio connection. And again, on the patient side, it's good to always have a telepresenter, whether that's a local physician, nurse, respiratory therapist, whatever it is, or family member to help describe how the patients, and if you need additional information, laboratories, or the patient to do a physical exam, that's an essential component of a telehealth encounter. And last, all of these encounters really need to be documented. Again, you're not going to have access to their electronic health record, but it is important for you to be able to generate an electronic health record on your own end so that you're able to document these encounters. There's lots of components to it. I mean, there's of course the equipment, there's having established telecommunications, it's how it's operationalized. And then there's lots of questions about like credentialing and increased liability, financial sustainability of these models of care outside of pandemic situations or surge responses, the etiquette, all of these different things. And so I can go kind of quickly through a little bit of these. We have on the patient side, typically in the emergency department, but also on pediatric wards, pretty standard video conferencing equipment with a plug-in pan tilt zoom capability so that I can direct the camera, a room mic on that and things like that. And then on our specialist side, we use headsets and directional microphones. It used to be big telemedicine equipment. You can use an iPad or tablet on a stick or even a handheld one. I think that the image quality and allowing the on-site providers to be able to touch and manage your own patient. I really like the hospital grade pole mounted equipment that I can direct the camera. And again, who owns the equipment? Are you expecting these outside ERs to own it? In general, you get what you pay for in terms of image quality. Do you need peripherals like otoscopes, a stethoscope, things like that? Our model, again, not saying it's right, but we own the equipment. We deploy it to outside ERs. We use high-end equipment so that our docs can see good images that way. And in general, we don't employ the use of peripheral devices because when we've had them, we just don't use that. And in terms of the operations, we've decided to integrate it into our existing workflows. So anytime you do a consultation, we have a 1-800-UCD for kids lines. That's the way you do it with the telephone consultation. And we're very quickly able to jump to say, hey, put the telemedicine unit in their room. We've done lots of physician training on both end, right? Our docs and the outside ER docs and pediatricians. We test it frequently. There's a 24/7 helpline that we have. And so that all the outside hospitals have to do is power it up and put it at their bedside. And there's different ways of documenting it too, right? You can document in the ER, outside ERs, electronic health record. In our circumstance, when we're connected to 35 different hospitals, we don't do it that way. We document in our EHR and then share those notes with them after the consultation. And we always leave it at the discretion of the medical teams whether or not to use telemedicine, because sometimes we're very busy on our end and not able to get to it, and vice versa. They may not be able to get to it on their end, but we really work hard to make it a painless integration into the existing operations.
Yeah, it seems like for so long, telemedicine was limited by the technology, right? But now, basically, an iPhone can let you do almost all these things, right? The technology is no longer the limiting factor. What's the limiting factor now is like, right, whose EHR are you using? What licensing responsibilities do you have between the hospitals? Can you talk about sort of those credentialing and liability and financial
Yeah.
model for this?
There is a credentialing issue, right? And so CMS has an approved process by which is called credentialing by proxy. It is Joint Commission approved. In California, it's CDPH approved, and they're all in alignment that you don't necessarily have to have full credentials and become members of the med staff at each of these hospitals, but you can do what's called a credentialing by proxy process, which should be a relatively short and painless way of doing credentialing. Another question is big about liability, but again, I think that liability insurance is probably overthought by the physicians. For example, we don't have increase in our liability insurance when we're connecting up to different hospitals, and you could even argue that it's reduced liability because hey, we're looking at the patient and not giving advice over the phone of what somebody else is describing. Of course, another big question is about the financial sustainability. In all of the models, that we do them all, and I'm familiar with all the other models where it's contracted rates, with a monthly rate. It's also, we do it with a lot of critical access hospitals where there's no charge at all, right? We're able to document our notes and we can bill for the note. But again, that's not why we're doing it. We're doing it to provide the most appropriate care to the patient in the ER. And if we're going to get the patient, that way it helps us more appropriately triage the patient when we're able to look at it. So, and there's also per click models of financial sustainability, but even though it does take some time and effort, it shouldn't be the main focus of why we're doing this. We're doing this to do the appropriate care of children.
Right. And we don't charge people to call the transfer center or ask to get a consultant on the line to talk about whether it could be transferred. This is just that augmented way of providing that same service in a way. Do you want to talk a little bit about sort of the best is the like etiquette side of things?
Yeah, I think, well, I can say that etiquette, right? So I do think that we have to be thoughtful on our end that we're not in the car or not on an iPhone or something like that, and that we have a headset. So what is happening at the outside facility isn't broadcast, a directional mic, so they don't hear background noise. And again, I think that if the family is in the room, that we need to continue to be supportive of our facilities that are calling for our help, right? They don't take care of kids all of the time like we do. So always being mindful of being respectful about the care that's being delivered. And if there's suggestions, do that professionally and thoughtfully. I think I can say, if, why isn't this happening a lot more? We can talk about why it's, telestroke is a standard of care. The use of telemedicine and ED psychiatry is a standard of care. Same thing with tele-ICU. There's a lot of financial reasons for these, unfortunately. Like in telestroke models of care, when an outside facility gives TPA or keeps a patient that otherwise might be transferred, that they're going to keep those revenues for those types of patients, higher associated DRG payments. Telepsychiatry can reduce the bed hours for patients that may not need to be held or institutionalized. But unfortunately, despite the growing bit of evidence that teleemergency in pediatrics improves the quality, the patient-centeredness, the family satisfaction, the safety of care, there isn't the big financial drivers that there are with these other examples, which is unfortunate.
If a place wants to get started doing this, what's next? What do they have to do to put this in place? And is it as simple as just setting it up the moment that you need it, or is this something that everyone should be thinking about proactively for the next time there's a triple demic, even if day to day they're not going to be doing a ton of telehealth?
So for me, the big thing here is adoption of these readily available models of care. In our model of care, we just have it. We have these calls taken by the doc that's on call, just like they would do the telephone call. To add video isn't such a big model of care. Other models have docs that just sit at stations and take these calls. And again, if you have the volume to be able to do that, that's great. We need to continue to advocate for at least parity in payment, if not augmented payment, because we're providing higher level care. And a lot of times we're saving health plans big money by obviating the need to transport patients. as technologies improve and the costs come down, I think all of these are going to make it easier for us to implement these types of models of care.
Right. I mean, from a global perspective, right, you think about one kid taking a helicopter flight for something that they could have just stayed in an emergency room for another 20 minutes for in their home community. And that pays for a lot of nice cameras, right? It's clearly the way of the future. And I think this is just
Yes.
enormously exciting. Let's talk about, best resources. If people want to know more, like where should we go?
Yeah, again, I think so. Here we have previously mentioned the American Academy of Pediatrics, the Sprout Network. There's a section on telehealth care that's associated with the American Telemedicine Association. RAPM, we continue to provide resources on that, as well as the other ASPR and CDC funded pediatric emergency preparedness centers. Up on top is the telehealth resource centers. Every state in the country is covered by one of 14 different telehealth resource centers, and it is their job through HRSA to be able to support both originating sites and distant sites. I think that there's lots and lots of resources. Folks can always reach out to me personally, and I can help them as well. And then on this slide here, I've listed some of the research that we've been able to produce here at UC Davis that support the fact that this model of care can have on patient-centeredness, referring doctor perception on quality of care, patient safety, and appropriateness of transfer.
Wonderful. Well, Jim Marson, thank you so much for taking the time to talk about this area of your enormous expertise. And we look forward to hearing more from you about the best way to develop telehealth resources in the months and years to come. So thank you so much.
Thank you. It's my pleasure.